Thank you, Timothy, for the introduction. Welcome, everyone, and good afternoon. Welcome to Houston. My name is Priyanka Iyer, and I'm going to be speaking about advanced thyroid cancer. I'm just going to share my slides so you all can see what I'm talking about. All right, so we're going to talk about advanced thyroid cancer. Those of you who did attend my previous session, we talked really about the basics of thyroid cancer. But what we all know so far is the classic treatment for any kind of follicular-derived thyroid cancer, that is either your papillary or follicular or Hürthle cell, is we would do surgery, then follow it up with radioactive iodine if it's necessary, and then your doctor would start you on thyroid hormone and talk to you about TSH suppression with thyroid hormone therapy. So what do we call thyroid cancer advanced, or when is it recognized as advanced? So one is if you're just presenting the very first time, that means you had no previous history of thyroid cancer, but you present with a bulky neck tumor, rapidly growing, and if you don't do something about it, it could cause breathing problems. Or if you had a previous diagnosis of thyroid cancer, previously treated with surgery, radioactive iodine, you've been taking your thyroid cancer, but now it's coming back, either in the neck or with distant metastasis. And this is despite taking thyroid hormone every day, your doctor's monitoring it, it is where it should be, but this cancer is coming back. Or if you have a surgical tissue or a biopsy which read poorly differentiated, high grade, or anaplastic thyroid cancer. So that means that you can't recognize whether it is papillary or follicular, a Hürthle, or what it came from. Or if your doctor thinks that this tumor is now advanced as it is behaving aggressively, that is, if they don't do something or whatever they are doing right now is not working for it. So why does it need a different approach? We just talked about earlier surgery, radioiodine, thyroid hormone. Why can't we just do that for it? Because so they can affect breathing, choking, they can cause you to choke, they can cause you to have trouble swallowing. And a lot of times it takes time to take you to the OR. They can't always take you to the OR just as you present to the emergency room. So if you don't do something about it quickly, you could have more problems. And sometimes surgery right away is not the right answer, because what if you don't take out all of the cancer? Or if you try to take out all of the cancer, you may cause problems. One can have more bleeding from it, that can be dangerous. One may lose a vocal cord because this tumor was now pressing on the vocal cord, so your voice could get hoarse. Or maybe you can take some of it surgery, but some of it needs additional treatment, let's say external beam radiation. So not the classic radioactive iodine, but something more powerful. Then the second category of advanced thyroid cancer is that which was previously treated with the traditional methods, surgery, radioiodine, but now it is progressing either in the neck or with distant metastasis despite thyroid hormone. So clearly the traditional approaches aren't working. The tumor has outsmarted these. So if old tools are not working, we need to find out why. Can we be smarter than the tumor? And historically, they used to give multiple doses of radioiodine. Give more iodine. Maybe your tumor needs more iodine. But then, as time went by, we discovered that it led to more side effects. Patients complained of dry mouth, loss of taste, dry eyes. They found their eyes had to be rubbed a lot of nausea right after radioiodine. And then, as time went by, we also saw second malignancies, lymphoma, leukemia. So now they don't have thyroid cancer, but they have a deadlier cancer. So then we really started questioning, is more really better? And then some doctor said, let's tighten the thyroid hormone dosage further. Let me give you more. Let me give you more. But that led to more side effects like heart problems, arrhythmias, osteoporosis, fractures. So now you didn't have an aggressive thyroid cancer, but you were in the hospital with other complications. So the third category is when we see tumor pathology, that is either a biopsy or your surgical tissue, which showed poorly differentiated, high grade, or anaplastic thyroid cancer. So when patients have surgery, the surgeon or their endocrinologist will go over the path report with them. And when you read your own path report, a lot of words look like medical jargon, mumbo jumbo. What does it mean? I don't know. But if you see any of these words, it means it's an advanced thyroid cancer. So sometimes this may happen despite having good prior treatments. That means somebody had papillary thyroid cancer, they had surgery, they got radioiodine, they were taking their thyroid hormone, and 10 years later or 15 years later, they may see this cancer has come back. And now it looks the way it looks here, poorly differentiated or high grade or anaplastic. And why is it important to recognize it? Because these cancers have poor prognosis. Anaplastic thyroid cancer is the deadliest. And you might have heard some of the sessions earlier yesterday where they talk about why it is important to treat it, what are the new modalities. And I treat anaplastic thyroid cancer, so I'm very familiar with it. And if left untreated, these advanced thyroid cancers, patients can barely make it beyond 6 months. So we need to do something. And most importantly, now there are novel therapies available. So we should allow our patients to get access to those. The fourth category is if your doctor thinks that the tumor is advanced or it's behaving aggressively. So that means it may be a papillary, it may be a follicular, it may be a Hutton, but it's not the usual behavior. What does that mean? That means it's growing rapidly. So can there be an anaplastic thyroid component to it? Or it's in an unusual location. Say it is on a bone, it is causing a fracture. Or it is invading your trachea or esophagus. That means if we don't stop it, it's going to go into your trachea or esophagus and cause trouble with breathing, trouble eating, swallowing. So that's when we call it advanced. So why does it advance and how does it advance? So you may have recalled my slide from my previous talk, but for those who are attending this the first time, so it's the number of mutations that get collected in a normal cell. So as and when they collect more mutations. What is a mutation? It's basically damage to the genetic material or DNA. You all understand DNA. So if there's damage to the DNA, as more and more damaged DNA gets accumulated, the cells lose their normal behavior and they become cancerous or malignant. So this is how thyroid cancer evolves. And in most cases, we see follicular adenoma with follicular cell or papillary carcinoma. And then, in some situations, it may progress to poorly differentiated or anaplastic. In some situations, poorly differentiated or anaplastic may arise de novo. That means there may not be a precursor like papillary or follicular. It may straight go to one of these advanced thyroid cancers. It's a smaller number though. So most patients who have poorly differentiated or anaplastic, they will have some kind of precursor differentiated thyroid cancer before it became poorly differentiated. So these are again a little bit of medical terms, but I thought this slide would be helpful to understand what do we find under the microscope? Why do we call it the way we do? So again, so these are the driver mutations. So, when we talk about mutations, what was the genetic damage that happened that caused this cancer? So one was, so most common is BRAF mutation, which is BRAF V600E. Then we see RAS mutations, NF1 mutations, RET fusions, NTRK fusions. So these are, genetic problems in your cell. So typically these molecules are there. We have a RAS, we have RET, all of us have it. But they have a certain role. That means they prevent people from getting cancer. That is their normal job. But say they get mutated, that means they're exposed to some kind of radiation or some type of toxin, which changes it and it starts misbehaving. So now it's no longer doing its job. And that leads to cancer. So typically they come broadly under a term called differentiated thyroid cancer. That is your papilloid follicles, and this is your Hurtle cells. And then as they acquire more mutations, you remember the first, second, third, as they acquire more mutations or more damage occurs, Now they start growing rapidly, and you can barely tell that they came from papillary or follicular HER2. And then there comes a point where they still retain the driver, that is your BRAF or RAS or RET, but now they have developed more mutations, as in the P53, third promoter, all of these, which makes them really aggressive. That means they have taken away the stop signs, they've taken away the speed breakers. So now when you don't have the speed breaker, it's growing rapidly, it just keeps going. So then as these tumors progress, the differentiation markers decrease. That means we no longer can follow thyroglobulin levels that we were following for differentiated thyroid cancer, because most of these tumors may not make thyroglobulin, or they may make very little. So what are the mutations in papillary thyroid cancer? And the reason I chose to talk about papillary derived, because papillary is the most common form of differentiated thyroid cancer, seen in 85% of cases. So the most common mutation in papillary is your BRAF mutation, which is 62%, followed by RAS, and then these are RET fusions or RET mutations that we see. So these are all the mutations that one sees in these thyroid cancers, which makes them behave like cancer. That means they can grow, they can spread, they can cause problems. So previously, we had a very straightforward treatment approach, right? Surgery. So we check, can you operate? Is it resectable? Yes, go for surgery. If no, if it's very small or if it's something that we can wait, then we would wait and observe. And then we would also see that, okay, if you can't observe, maybe there's a recurrence in thyroid bed. The patient already had surgery. Can you just give more radioiodine? If they have uptake, then sure. If no radioiodine uptake, we would say, okay, let's watch it to see if it grows, or try to do another surgery or do something to help it. So historically, we used to follow the slash, burn, and suppress algorithm. That means slash is surgery, burn is burn with radiation or radioactive iodine, and suppress the tumor from growing with more thyroid hormone. But what do you do if this cancer comes back despite doing all of this? So that led to the evolution of treatment of advanced differentiated thyroid cancer management. So back then in the 1930s, we first had the thyroid hormone, which if you gave more of it, it kept the cancer in check. Then we did in 1949 how they first used it for metastatic thyroid cancer treatment. And then as years went by, they discovered that radioiodine was not good alone. So they discovered chemotherapy. And then in the 2000s came the TKIs or tyrosine kinase inhibitors or oral chemotherapy that some people talk about. So these are all pills. These are pills. These are different types of pills. The first one was sorafenib, which was FDA approved. Then came lenvatinib. Then came dabrafenib, trametinib, larotrectinib. So these are all the drugs that are currently available for treatment of thyroid cancer. And then we got even more creative. In the 2010s, we came up with combination therapies. Maybe one is not good alone. Maybe we need to combine it with something. Maybe we can combine these oral pills with radioactive iodine, which we will see in redifferentiation therapy. Or maybe we could use these drugs specifically towards the mutation that is causing a problem. And that is great because when it is mutation targeted, they have less side effects because they are mainly targeting that specific mutation. And now we are talking about immunotherapy. So I'm going to go into details of majority of these. So let's take a look at the thyroid cell. So this looks very busy and very, scientific, right? But the reason I put this here is so you understand that when your doctor uses words like, oh, you may have a BRAF mutation. So they're talking about this pathway. That means your cells are growing along the RAF MEC and there's a problem over here. So because there's a problem, your cancer is growing and there's nothing to stop it. Or there is a mutation along the RAS. So that means it is uncontrolled along both pathways. Or there's a problem with the PI3K, or there's an mTOR pathway issue. So when you hear these terms used by a doctor, it's very important to think of what they're talking about, or at least when you Google these images, you can understand that they are talking about a blockage or a problem in one of these molecules, which is causing uncontrolled growth. And what I have highlighted here are the drugs that are anti-angiogenics, meaning they just cut off the blood supply to the tumor. That means whether it is lenvatinib, sorafenib, or cabozantinib, they don't work on any of these mutations. And this is what we used to use, and we still use a lot more when we cannot identify which mutation it is. And the beauty is they act at multiple levels. So when you just cut off the blood supply to the tumor will not grow. So that is the main principle. And that's why they are called anti-angiogenic, meaning anti-blood vessel. Angiogenic means blood or creating blood vessels. So it basically prevents the tumor from creating more blood vessels. So when it doesn't get blood, it doesn't get food. When it doesn't get food, the tumor will die. So how do we use all these tools that we have now? How is it different from earlier? How do we choose which one to use? So first we divide the situation into three scenarios. We first try to evaluate the patient's case and see, okay, is this locally advanced? That means are they presenting with a large tumor in their neck, or it's not large, but even though it is small, it is invading into vital structures, or are there distant metastases like in the lungs or in the bone or in the liver, or is the problem its genetic makeup, or is it anaplastic or poorly differentiated? So first we try to identify what is the problem. So let's talk about the first problem, that is locally advanced disease. Like you can see here, this tumor is large, right? It's bulky, and his airway looks okay over here, but here when you look lower, it doesn't, you can't tell. Maybe it is invading into some vital structures. So first what we do is we first identify the type of cancer. So we don't just do a fine needle biopsy. We also collect extra tissue mainly to identify what is causing it. So unlike the usual thyroid nodule management that you learned about earlier, this is handled differently because we know that this is advanced, this is bulky. So we may need to do something differently and we want to identify what is causing it. So then we do a molecular testing. So you might have heard of Afirma, you would have heard of Thyroid C test. My doctor sent an Afirma, he sent for Tempus or Guardant, a foundation one. So those are just testing platforms or testing companies which take your tumor tissue, stain it, and identify what is causing your cancer. Then what we do is once we identify the driver, we get creative. So instead of doing an incomplete surgery, leaving cancer behind, we try to see, can we shrink the tumor before we take them out for surgery? Maybe if it's a smaller tumor, it will be easier to take it out. It will have less problems. So nowadays we use something called a neoadjuvant approach, preferably in a clinical trial. And then once we start the drug, we assess response in 2 to 3 months. That means your doctor will repeat your scan, whether it's a CT neck, CT chest, or ultrasound, and see has the tumor shrunk. And if it has, they will take you up for surgery when it is safe to do so. And then once they do the surgery, they may follow it up with radioiodine, similar to your general garden variety differentiated thyroid cancer. And then the surveillance continues with your ultrasound and TSH suppression. So then we talk about how do we identify this driver mutation. So these are the guidelines that were laid out. So once advanced differentiated thyroid cancer is identified, then this again looks very scientific, but there are mainly two ways of testing. Either you try to find out what is the one problem this tumor has, or we want to look at the entire genetic makeup of the tumor. We sometimes say, I just want to find out the driver, what is causing it. Or sometimes I want to get all the information because it's not just the driver, but there could be other mutations which influence how this will behave or how this will respond. So the tissue-based panels that they're talking about here, they are very expensive though. So sure, they give us a lot of information, but they're expensive. And because it's more exhaustive or comprehensive, it can take time. It takes 10 to 14 days for the results to come back. So if you want an answer quickly, you may not get a very satisfactory answer fast enough. But if you do the multi-step testing approach, that means we try to go after what is the most common. You learned earlier, papillary thyroid cancer is most common, and the most common mutation is BRAF. So it is cheaper because you're going after just one gene. So we try to find, is it BRAF positive? Then we know what drug to use. We'll use a drug which is targeting this specific mutation. Say BRAF comes back negative. Then we look at what next could it be? Could it be a red fusion or could it be NTRK? And depending on what the result comes back, we treat it with the drug. Now, you might have seen there was RAS mutation, which was the other one we mentioned earlier. Unfortunately, we don't have a RAS drug or a drug which is targeting that just yet for thyroid cancer. So let me give you an example of what we call, locally advanced disease. So this was the CT scan. So when you look at the CT scan, this is the jaw, the lower jaw. This is the back of the head. These are the vertebrae. This is the neck. And you can see like there is stuff here, but this looks abnormal, right? This looks like it's not there on the other side. So this is what is the thyroid cancer over here. And if you look at it in a different view, you can say that it's invading the neck muscle. Do you see it? It's eating into the neck muscle. So if this patient were to just undergo surgery, then and followed by radioiodine radiation, you have so much of this tissue in the muscle. It can cause problems for the patient after surgery. So if we were to just look at the traditional treatment options, this patient would have a lot of post-op complications. So then they had molecular testing done. And this was that showed a BRAF mutation. Now, I just wanted to add that this image that you're seeing is of a patient who's already had thyroidectomy, and this has come back. So this is not the first presentation. He's already had surgery, he's already had radioiodine, he's taking his thyroid hormone, but now, despite doing everything he should, the cancer has come back. And you see that we did molecular testing, which showed BRAF V600E. So then we changed our approach and we said, let's shrink this tumor so we can peel it off away from these muscles and then follow it up with surgery. Otherwise, we may end up cutting off this muscle. So then what happened? This was the baseline imaging that you saw. But after 2 months of drugs, voila, you don't see the tumor anymore. Guess what? You didn't need surgery anymore. So these drugs can cause shrinkage enough to either take you to the OR in a safe manner, or maybe they'll just get rid of the tumor entirely. So why not consider it if we can avoid a second or possibly a third surgery in our patients? So let's talk about neoadjuvant treatments and what are those. So we currently do have a lot of clinical trials which are looking at neoadjuvant. What does the term neoadjuvant mean? Neo means early or before definitive treatment. So it's an adjuvant. Adjuvant means like an additional treatment, but before definitive treatment, which is your surgery. So one of them is the one which is currently open and enrolling is a RET fusion directed or a RET mutation directed, where we use this drug called selpercatinib before surgery. Then if you don't have any targetable mutation, then you can even use lenvatinib. Remember, lenvatinib was the drug which cuts off the blood supply to the tumor. So maybe you could shrink it by cutting off the blood supply safe enough to have surgery. And then if there's a BRAF mutation, and this is mainly for anaplastic thyroid cancer because the drug dabrafenib trametinib is FDA approved for anaplastic thyroid cancer, so it is easily available. And we use that in combination in anaplastic thyroid cancer before they have their surgery so they can have a meaningful surgery. Then we come to the next category, distant metastasis. You remember we talked about the first, that was the bulky. The second one was this is a patient who has distant metastasis despite taking radioiodine in the past. So then the doctor may do another whole body scan and they may see that, okay, the CT scan showed these lesions, but the whole body scan is not lighting up. So if you remember from my previous talk, I had mentioned that sometimes the diagnostic scan will be negative, but the SPECT CT may show something or the post-treatment scan may show something. So now we don't see any uptake of radioiodine. Or there may be 3 lesions which have taken up the radioiodine, but one did not. Or all of these took up radioiodine earlier and they still do, but these have grown. So is radioiodine even doing anything here? So they may be treated with radioiodine, but it did not do much for them. So why use the same tool over and over again when it's not doing anything? Or when it did something for a few of them, but there is one which is growing and is not going to respond to that tool. Or this tool will be useless over here because it doesn't take up radioiodine. So then we discuss with the patients, when should we treat it? Just because there is disease, do we really need to treat it? We don't. That is a simple answer because differentiated thyroid cancer, that is your papillary or follicular, they're very slow growing cancers. And that's what we call indolent. That means they're very slow growing. And not always you need systemic therapy or chemotherapy. Why? Because these chemotherapy drugs have a lot of side effects. So we assess, we see, can we suppress the TSH? Can we adjust the dose to see if it works? If not, then we try radioiodine again. You remember we did that whole body scan where you saw those red dots? Whether we check basically, can we give more radioiodine? So if yes, you could try it one more time, or if not, we try to observe. Okay, it doesn't take up radioiodine, but let's see whether it is growing. And if it is, how fast it is growing. And then if it is growing, we may again do a diagnostic scan to see if now it is taking up radioiodine or not. And sometimes it does, sometimes it doesn't. And then sometimes we see that, despite radioiodine or, despite TSH suppression, this lesion is growing, say in the bone or in the lung. Can we operate and just take that piece out and be done with it? That could be an option. Or can we just radiate that lesion, use radiation, just an external beam, and knock it off? Maybe that's an option. Or you could embolize it or ablate it if it's in the liver, because that way you've addressed the problem tissue or problem gland. For bony metastasis, that means cancers which have gone to the bone, say the rib or the vertebrae or the leg bones. We use certain drugs called zoledronic acid, also known as Zometa, or denosumab, also known as Xgeva. Can we use these drugs to slow down future tumor growth in the bone and also prevent a fracture? But if despite this, you've done all of this, you've tried one or more of this, but it's still progressing, then we try to assess, is it clinically significant? That means, did it grow from 1 centimeter to 1.4 centimeter over 6 years? Years, not months. Or is it growing 1.1 centimeter to 1.6 centimeter in 6 months? Or is it really progressive? And if we don't do something about it, it can affect either breathing or swallowing or something. If yes, then we consider targeted therapy. So remember, targeted therapy is therapy or pills that you can use to target whatever is causing that cancer. Okay. So then we talked about, we'll talk about redifferentiation. So you remember I talked about you could do more radioiodine if needed, but how do we do it? So when we identify that, this is the pre-treatment scan, diagnostic scan, we identify they have a BRAF mutation. We give BRAF inhibitors to block that mutation because despite giving radioiodine, this cancer progressed. Why did it progress? Because of that mutation. So we block that mutation and then we follow it up with radioactive iodine. Similarly, for the RAS mutated tumors, we have seen in clinical trials that using MEK inhibitors can be used to make radioiodine more effective. So these were the trials that looked at selumetinib, trametinib, cobimetinib. So you see, they were not taking up radioiodine earlier, but after you treated them with the drugs, they are now taking up radioactive iodine, and you can still use radioiodine up for treatment purposes, but in the presence of these drugs. So let me give you another example, which was published from our center. So this was a patient with follicular thyroid cancer, okay, with the NRAS mutation. And like you can see here, this patient had a lung metastasis, which was growing. So the doctor did a whole body scan, and they found that it was not lighting up on whole body scan. But this patient was thriving, very active, having a full-time job, did not have any symptoms whatsoever. So the doctor and the patient decided to observe. So you can see here, they were watched between January 2016, then 7 months later, then again 7 months later. So every 6 to 7 months, they had scans and blood work. And you see that the thyroglobulin, that's the tumor marker, was growing surely but steadily. So it grows from 188 to 871 over 3 years. So clearly the cancer grew, but it took 3 years. By then, they had this opportunity that instead of giving more radioiodine for something that's negative, the doctor had read about the selumetinib clinical trial. And they said, okay, selumetinib is not commercially available, so let's try a similar drug, trametinib. So that patient received trametinib for 40 days. They got the shots, the thyrogen before radioiodine, and then they had dosimetry. Remember, I talked about dosimetry in my previous talk, where we said what is the safest dose of radioiodine that this patient can receive, and they calculated to be 200. So now on this chemo or on the trametinib, you can see that this scan, which was negative, is now showing the lung lesions. So would you treat with radioiodine? Yes, because they are showing uptake. So then this patient was treated with 200 millicuries of radioiodine. The chemo was stopped 72 hours after, and the post-treatment scan lit up even brighter. Because remember, even in our first talk, we saw that the diagnostic scan may not show everything, but the post-treatment scan may really show all the disease. And they even found this new lesion in the bone, which was then treated with radiation. But the SPECT CT showed this lung nodule. And then 1 year after radioiodine, the thyroglobulin dropped to 35. So you see this from 871 came down to 35, and the lung nodule is barely visible. Where it was here, and where is it now? Impressive response, right? So then there we chalked out a workflow, like when do we treat, how do we treat. So one is if either, this patient's tumor cannot be controlled by local therapy, or the tumors are growing rapidly, more than 1 to 2 centimeter diameter, or more than 20% yearly, then we look for next steps. If no, we continue treatment with TSH suppression and continue to monitor this metastatic sites every 6 months. And if it's growing, then you would either consider a clinical trial, or if clinical trial participation is not an option because you don't have a center close by, or it is too much of travel, or whatever the reason might be, then look for the driver mutation. Do they have an NTRK, a RET, or a BRAF V600E mutation? Because there are drugs commercially available now, so you don't need to go too far. You get these through insurance. So instead of bombarding with more and more radioiodine, there are novel treatments available and covered by insurance. So why not use those? Then, if there's a BRAF V600E mutation, I will say this. The dabrafenib and trametinib is approved for anaplastic thyroid cancer. It's not approved specifically for papillary thyroid cancer, but these days the FDA approvals are not limiting themselves to the tissue. That means it doesn't have to be approved for thyroid cancer. These drugs are now approved for any tumor which has this mutation. So regardless of whether it is thyroid or melanoma or colon, you can use the dabrafenib and trametinib. But given that it is not specifically used or approved for thyroid cancer, we first try to treat with an MKI or an anti-angiogenic, which cuts off the tumor supply, that is lenvatinib. But these drugs have side effects, and one of them is excessive bleeding, high blood pressure. So if patients already have poorly controlled blood pressure or a risk for bleeding, then we look for a BRAF and MEK inhibitor. So that's how we have a workflow. And then this is something you can have a discussion with your doctor about. So these are the same anti-angiogenics that I showed earlier, just to recap, which we use to cut off the blood supply to the tumor. If you have a contraindication, then you can look for specific mutations and target that. So now what happens if somebody has poorly differentiated or anaplastic? Now remember the first picture I showed, the locally bulky tumor. There you could at least look at the margin of the tumor. Can you see the margins of this tumor? Maybe you can see this one, but you can't see anything over here. So these tumors are very classic. When we see this, we are worried about anaplastic or poorly differentiated because they're so large, they're invading a lot of structures. So if we don't do something about it quickly, patients can die. So again, we first identify the type of cancer, always confirm the diagnosis. Then we look for a BRAF mutation. This is always the next best step because there are FDA approved drugs available for the BRAF mutation for anaplastic thyroid cancer. So you could use it for that. And some of these patients we need airway support. That means if we are waiting for this molecular testing, which at our center, the BRAF takes about 24 to 48 hours, whereas external centers may not have a quick turnaround time. In the meantime, we don't want the patients to have trouble breathing. So sometimes they may get a tracheostomy done. If BRAF positive, then the recommended treatment is dabrafenib and trametinib. But from our own center, we have data to show that these drugs alone may not be very effective. So it should be combined with pembrolizumab or immunotherapy, preferably on a clinical trial. Why? Because these are not FDA approved combinations when you combine it with immunotherapy. So it's best to do it when it's experimental, it's best to do it on a clinical trial. If BRAF negative, please request a referral to a tertiary center for a clinical trial. We are a tertiary center at MD Anderson. We have a FAST program. We see a lot of anaplastic thyroid cancer patients. We have a lot of clinical trial options. So a lot of times outside, some doctors may say, oh, this is very aggressive. You need to go to hospice or you need to consider hospice. And a lot of patients don't get this option. So that's why I'm educating everybody here. Should you know somebody who needs a referral, please encourage them to seek a referral. So here I'd like to show you an example of a patient with anaplastic thyroid cancer. This is the PET-CT. You remember in the first talk we said the PET-CT is bright and in those tumors that are very active. So this is the planar image. That means this is the black and white image of that. And you can see how big this tumor is. This is when they first presented to MD Anderson. And then after 3 months of therapy with the BRAF inhibitors, that is dabrafenib, trametinib, and immunotherapy, you see how tiny the tumor is? This patient had meaningful surgery and he's still alive 7 years down the road. So then we come to role of immunotherapy. We talked about its use in anaplastic thyroid cancer, and what the studies have shown so far is that you can't use it by itself. That means you can't use it as a single agent. It's not effective. It doesn't do much. But it has been recommended for using in combination with targeted therapy for anaplastic thyroid cancer. So instead of just using the pills, we always combine it with immunotherapy because it's been shown to be effective. And it's actually now recommended by the National Cancer Consortium guidelines. Immunotherapy has also been studied in patients with differentiated thyroid cancer. That means not the ATC pearly diffs, but the papillary, Hurthle cell, folliculars. So those patients who tried lenvatinib, but the cancer still progressed, there was a clinical trial which added immunotherapy, and we saw that this combination was safe and also helped slow down the progression of the disease. However, keep in mind, immunotherapy is currently not approved for use in thyroid cancer. So why is this important? Because if we try to order this commercially, insurances may not approve it. So your doctor has to, talk to the insurance company or do some kind of prior authorization. And if denied, you'll have to go through a patient assistance program of sorts to get it for the patient. So to summarize, advanced thyroid cancer needs a different approach from the slash, burn, and suppress approach in DTC. Molecular testing plays a major role in treatment planning. So please seek out moleculars. And a multidisciplinary approach may be needed early in the treatment. That means you may need an endocrinologist, you may need a surgeon and a radiation oncologist all at the same time, both at the time of diagnosis, that means when you first present, as well as when it progresses. And ideally, the combination treatments, when sought out, should be sought on a clinical trial. With that, I'd like to end my talk for advanced thyroid cancer, and I'm happy to take any questions.
We do have a few questions in the Q&A.
Yes.
The first question is,
yes.
How do you handle TSH suppression in a poorly differentiated thyroid cancer that is high risk, that has been suppressed for 14 plus years to a very low level, that is now causing a lot of atrial fibrillation, and that was previously controlled by medications and is no longer being controlled? How would you handle that TSH suppression?
That's a great question. So we always have a discussion on risk versus benefit. It really depends on how the poorly differentiated thyroid cancer is also behaving itself. So, for example, sure, 14 years ago, the pathology showed poorly differentiated. But if there is no current evidence of disease, then it makes no sense to, suppress at the cost of side effects to the patient. So we back off. It also depends on the thyroglobulin level. So if the TSH suppression is helping keep that thyroglobulin in check, if that poorly differentiated cancer is making thyroglobulin, then it has some role. But again, patient safety first. So if this patient was my patient, I would have said, listen, if the thyroid that's what your doctor did and lowered the thyroid hormone. But if not, I would highly recommend that.
Dr. Iyer, I'm not sure if it's just me, but you did cut out there for a minute at the end of your last statement there. If you could repeat at the end of what you just said.
Yes, so I said in the end that if this thyroid cancer grows or progresses, they should lower the thyroid hormone dosage. If they haven't done it, I would highly recommend asking for it.
Thank you. Our next question comes from somebody who is interested in clinical trials. They're looking at a clinical trial for something that would be a stage 3 multifocal metastatic papillary cancer for an over 45-year-old person with the tumors and lymph nodes greater than 4 centimeters. And they're saying that the most recent study they can find is from 2009, and they're wondering if there's any newer studies than that.
So these studies that you're referring to from 2009, the stage 3 multifocal metastatic PTC over 45, the reason they get published is because a lot of them are retrospective chart reviews or prospective cohorts. The reason we don't have any recent ones is that most of these patients, even despite the extent of disease, that is lymph nodes and multifocality, they still continue to do well. That means they don't have a 10-year or higher, they don't have a very high mortality rate. So this cancer can be a bother. That means it can keep coming back. That means, you may need additional treatments. But a lot of people have moved away from these kind of studies because it's already established that if they come back, we have to treat them. But in general, they continue to do fairly well.
Our next question, I want to see if there's any questions in the in-person audience.
Yes.
Susan, are you able to see if the in-person audience has any questions?
Hello. Hi. Since you were talking about patients and cost and things long term, I've heard that using brand thyroid like Synthroid or Levoxil is better for cancer patients versus generic. Could you comment on that, or is that a myth?
So it also depends on there is one paper which showed that there was benefit to using a brand name or could be Synthroid or whichever, mainly because if you use generic, it would depend on the additives used in the preparation of levothyroxine. The additives may vary. So when you use generic levothyroxine, although the dose of levothyroxine will still be the same, just for an example, 100 microgram. So 100 microgram will be the same, but the preparation may vary from brand to brand. So that's why they say to maintain consistency, it's better to stick with one brand. But that being said, the additives don't contribute to how your cancer performs. It's the levothyroxine. So what we have seen from our data is that if you even do generic levothyroxine, you will have a equally good response because it's the levothyroxine which is suppressing your cancer and not the additives. But in some patients, it's also the tolerance. Like some people don't tolerate a generic one because of the coloring agent or the additives. So then we tend to stick with the brand name Synthroid. Yes.
I
Go
had a
ahead.
question about the BRAF mutation and
Yes.
if that is always considered to be an aggressive factor in papillary cancer, even if it's not advanced papillary cancer. And would you always keep someone's TSH suppressed if you have a BRAF mutation, even if it's not advanced?
Excellent question. And this is a conversation I think I have with a lot of patients in my clinics all the time. So when one has the BRAF mutation, it means there is a 30% risk for recurrence from original diagnosis. So in the first 5 years, there is a higher risk for recurrence. That is 30%. So in the first 5 years, I like to keep the TSH suppressed between 0.1 to 0.5 as per our ATA guidelines, which are from 2015. Now, when the guidelines change, it may be different, but for now, we follow those guidelines. Now, even though it is a BRAF mutation, what does it mean? It means that while the recurrence rate is high, it may not necessarily mean that it is more aggressive. But to specifically answer that question, you have to look at the next generation sequencing. You remember the comprehensive test I talked to you about, where there was one where it was single gene and one was multiple genes. So the other mutations will help me answer that question. So, for example, if you have a BRAF and TERT mutation, yes, that is going to be very aggressive. That is where I would monitor you every 6 months, but will also keep that TSH suppressed within that zero point 0.1 to zero point 0.5 longer than somebody who doesn't have a TERT mutation. So the molecular makeup of the tumor comes in very handy in determining what the next steps are, or how much we follow, or what prognosis the patient has. So we need more information than just the BRAF. So if you just have a BRAF and nothing else, even on the the whole sequence, the next generation sequencing, then after 5 years, we assess to see what is the extent of the disease. That means, do you have anything in the neck, in the lymph nodes? If no, good. If your thyroglobulin is undetectable, great. Then we back off to the next level of suppression, that is under 2, that is 0.5 to 2. And then we assess you every 6 months. Because keep in mind, it still has a recurrence potential. So it's not like we are free from that. It is more a bother where we'll keep bothering you every 6 months with an ultrasound and blood work than a worry. Does that make sense? Like it doesn't worry me to that, okay, if it's come back, I can handle it. But it's more a bother that, you'll have to do the ultrasound every 6 months, etc. But not all BRAF doesn't mean that it's aggressive. It's what is present in addition to BRAF that can make it more aggressive. Does that answer your question?
Okay, and speaking of TERT,
Yeah.
poorly differentiated patient diagnosed 4 years ago that
Uh-huh.
has distant mets to the lungs. How common is it to just have a TERT promoter and no other driver mutations?
It is seen. It's not very common, but it is seen. Like if you remember my first few slides, and I can show you which one I'm referring to. There was, we had that where the advanced thyroid, or poorly differentiated, came up from this one, from de novo. So sometimes we just see tumors with a TERT or TP53 without a driver mutation, but TERT mutation in itself is associated with widely metastatic thyroid cancer, and so it needs a novel approach.
And what medications do you typically prescribe for that
So if there is
situation?
no driver mutation identified, then we use lenvatinib, which is the anti-angiogenic, or the one that cuts off the blood supply to the tumor. You remember I showed you this diagram where you have this VEGF receptors, and that's what we use if there is no contraindication. If there is a contraindication, we may have to still work with that, but start at a lower dose and gradually titrate upward as tolerated.
So a level or lenvatinib over cabozantinib?
Yes, because cabozantinib is approved for use as a second-line drug if you have failed lenvatinib or other TKIs, or if you cannot tolerate lenvatinib. So cabozantinib is slightly better tolerated than lenvatinib. That's why they first try lenvatinib and then go to cabozantinib.
Thank you.
Sure.
Dr. Iyer, I have a question. Can you just explain a little bit about the full genomic sequencing testing? And if somebody does have advanced thyroid cancer, how many mutations is like the protocol? Because as I've heard, 100, I've heard 400, I've heard 600. Can you just explain a little
Yes.
bit about
So
that?
are you still seeing my screen? I just want to make sure you are. No? Okay, let me just share it. Sorry. Let me make sure you're looking at what I'm talking about. So how many genes do they check for? So it depends on which company you go to, and how many mutations your doctor wants. Honestly, we just want a handful of them. What we use at MD Anderson is a 648 gene one. Then there is Boston gene testing, which is in clinical trials right now. Then there's Tempest. So what we want to know are, the more information, the better, because what we don't know now, or say you find a unique mutation, you may understand the significance down the road, like, because thyroid cancer patients usually have a good lifespan. So maybe 4 years or 5 years or maybe 10 years down the road, we may actually have a drug for it. So as comprehensive it can be, we would like it. But when we do these tissue-based NGS cancer panels, we want to make sure that it covers gene rearrangements like ret fusion or ALK fusion, copy number variations, etc. Because the mutations that are present in addition to the driver mutation tell us whether this patient is going to respond to this drug or may develop resistance down the road. So that information is very helpful.
We've got
One more question.
quite a few questions coming in via the Q&A as well. So
Absolutely.
I'll read the next one if that's okay.
Yes.
This particular survivor was told that her genetic variants were ATM 45.0 and PL-L1 expression. And this is all from the Tempest test. She's newly diagnosed and still learning, so she's trying to get a grasp on what those mean.
So the ATM mutation is not a known driver mutation, but it is one of the secondary mutations that affect how this tumor behaves. And ATM does tend to be a little on the aggressive side. That means you will need monitoring. But I'll have to look at the Tempest test report really to see what the entire report was, because I don't understand PLL1. I'm guessing it is PDL1 that you're referring to. Um, if it is PDL1, that will give you a score. So higher the score, you are more amenable to immunotherapy. But again, immunotherapy is not used as a single agent for thyroid cancer, so it has to be used in combination. But again, these treatments are used only if there is extensive disease. So if you were newly diagnosed and it is all confined to the thyroid or something, then we still stick with the definitive treatment, that is surgery, radioiodine, and TSH suppression. But we can counsel you that the ATM mutation can be seen in certain aggressive thyroid cancers. So you will need ongoing follow-up with your doctor.
Our next question asks, how do you find out if Hürthle cell cancer has spread if it is RAI non-avid?
Very good question. So, Hürthle cell thyroid cancer usually makes thyroglobulin. So, if the thyroglobulin numbers are going up, then definitely it would prompt me to search more. We don't use a whole body scan, we use CT scans. Typically, Hürthle cell can go to the lungs and bones and liver. So, that's where I would look with a CT scan. And also a PET CT. So Hürthle cell cancers, interestingly, they don't take up radioiodine or don't show up on whole body scans, but they respond, they light up on PET CT scans. So your doctor may ask you to do a PET CT for that.
I have a question. What do you tell patients when they come and ask what's the risk for their children if they have thyroid cancer?
That's a very good question and very commonly asked. So it depends on what type of thyroid cancer they have. So if it is medullary thyroid cancer, we always offer genetic testing to look to see whether it is germline. Germline meaning it's in the chromosome. So if it is germline mutation, then it will tend to run in families. So that is for medullary thyroid cancer. But if it is papillary or follicular or Hürthle, we haven't identified so far, and research is ongoing. But so far we don't see a germline mutation that is handed down in families. So we often reassure our patients that just because you have it, it's not something that you will give your children or grandchildren. With that being said, like I mentioned earlier, that these mutations are caused largely by environmental exposures. So if you were all growing up in the same environment, or if you're still living in that same environment, for example, I have some patients who work near nuclear power plants, live near nuclear power plants. So in those patients, their families may be at a higher risk of developing thyroid cancer than somebody who's not living close to a nuclear power plant. But is it because their mother or father or the patient passed it on to them? No, it's because of the environmental exposure.
Thank you, Dr. Iyer.
Yes.
Our next question, I'm going to actually group together a couple of them. They're asking about immunotherapies. And it's, are there any clinical trials using immunotherapy for thyroid cancer, first of all? And secondly, how would we tell if immunotherapy would be helpful in a papillary RAIR positive and a BRAF lung mets survivor? Any additional testing would be needed for that as well.
Okay. So to answer your question, so let me start with the second question first, because going to clinical trials would first require testing. So how can we tell if immunotherapy would help a papillary patient or not? Yes, so there is an additional test. And like one of the participants had asked earlier about a PDL1 score. So you can ask for a PDL1 score on the tumor tissue. And this is done in the hospitals themselves, like by IHC, that is a single gene test. You can ask for PDL1. That's what we offer at MD Anderson. You can also do it through Tempus. So Tempus is one way, or even Garden. Any of these platforms these days, they do look at the PD-L1 score if the doctor has asked for it. So in some forms, when we are filling up the forms for external, ordering forms, there are boxes. So we have to choose whether you just want the mutations, you want the PD-L1, you want the fusions. I usually tend to mark everything if I specifically want it. But for the single gene test, we don't ask for just PD-L1 alone, unless if we know the driver already and we just want to know if immunotherapy will be an option, then yes, we check for PD-L1 alone through IHC. So the additional test is IHC or immunohistochemistry that is offered at MD Anderson. Or you can, if you're not at MD Anderson, at whichever hospital else you are, you can ask your doctor which one they have, but they can order additional test for that. Then coming to the next question, are there any clinical trials using immunotherapy for thyroid cancer? Yes. You can look up on clinicaltrials.gov. There are multiple sites, but there was a clinical trial which is now closed, and the paper was recently published where they used pembrolizumab or immunotherapy in addition to lenvatinib. So that paper was recently published, and they found it to be helpful. But existing clinic, so it also depends on which type of thyroid cancer. So for example, we do have immunotherapy clinical trials for anaplastic thyroid cancer, poorly differentiated thyroid cancer at MD Anderson itself. For papillary or follicular, you may find that information on clinicaltrials.gov. But you can even ask your doctor to, if that is something you want to consider as a treatment, the first step would be to check the PD-L1 score, and if it is something that is an option, then immunotherapy can be ordered even outside the clinical trial, though we don't highly recommend that. But if you don't find a clinical trial, it can still be offered, and the doctor just has to go through the ordering process with the insurance to get it approved for you.
Dr. Iyer, we are also about out of time. I want to see if we can squeeze in maybe one more question here, and I'm sorry we couldn't get to all the questions today from all of our participants. The next question is, how would you handle multiple large mediastinal lymph nodes pushing on the trachea? This particular survivor has tried lenvatinib, carboplatin, radiation to the lymph nodes, and there are also small nodules throughout the lungs. Currently, the thyroid globulin is doubling every 4 to 6 months and is now 7,000, and the mutations are NRAS and TERT.
Yes. So then you want to look into a clinical trial for the RAS mutation. If you have the NRAS Q61R, there is a clinical trial at MD Anderson. You can inquire with your doctor for referral to that. It's not by our department, but it is by the phase 1 department. But clinical trial would be an option. If clinical trial is not an option, then you can ask for the PDF. So you want to biopsy this tissue again because it has seen lenvatinib, it has seen cabozantinib. Maybe this tumor now has new mutations, which is making resistant to those drugs. Or maybe they have a high PD-L1 score. You could add on immunotherapy to lenvatinib or cabozantinib. So that is something to discuss with your doctor.